My name is Joe Burns. I'm the health reform and insurance topic leader for the Association of Healthcare Journalists. Joining us today is Dr. Mark Fendrick. He's an expert on the need to make preventive healthcare services free for all Americans. He was one of the founders some 24 years ago of the Center for Value-Based Insurance Design at the University of Michigan. He also was instrumental in introducing the provisions in the Affordable Care Act that call for Americans to have no-cost preventive screenings for diabetes, hepatitis, and some forms of cancer. Today, I want to thank Mark for joining us. And we had some news yesterday, Mark, from the U.S. Preventive Services Task Force on breast cancer screening, which we'll get to in a minute. But first, I would like to ask you if you could just distinguish between value-based care and value-based insurance design, and then just do that quickly, and then we'll talk about the case that's wending its way through the courts. But first, I just want to make that distinction. Value-based insurance design is what?
So, sure, Joe. Thank you, and to AHCJ for having me. It's a great pleasure. As a practicing physician and an academic, I like to tell folks that I published and I still perished, which is why it's so important that your colleagues at HCJ are so important. I see several of the folks that I've worked with over the years already attending, so it's a great pleasure to be here. So the term value in healthcare is somewhat ubiquitous now, but when I started, which I like to say in the last century, the idea of getting more health for the dollar spent was somewhat new. And as you think about healthcare and healthcare transformation and reform, there tend to be kind of two specific ways. One is provider-facing initiatives and how you pay clinicians and hospitals and health systems. That is typically referred to as value-based payment or value-based care. I have tended to focus not on how we pay people as much as actually how we engage my patients and the millions of Americans who seek care. And how we seek care is what I call more of a demand side initiative. And it's largely influenced through insurance design or how healthcare insurance benefits are created. And the basic healthcare insurance that we have in this country is the most important and commonly used patient-facing initiative is cost sharing, which is either in the form of deductibles or co-payments. And I like to refer those as blunt in the fact that Americans pay more for all care, whether it be the care I beg them to do, which I believe there should be minimal or no barriers, as well as the care for which the evidence doesn't show that there's a benefit and sometimes causes harm. So instead of the typical benefit design, which is this blunt, everyone pays more for everything, my colleague Michael Chernew and I, here at Michigan at the time, he's now at Harvard and chairs the Medicare Payment Advisory Commission, we thought, what about an idea that would have an insurance product that instead of setting your out-of-pocket costs based on the price of the service, such that, Joe, the cheap things are cheap and the expensive things are expensive, what if we actually created a benefit design where the things that were most beneficial to your health were little or low cost, and the ones that wouldn't benefit you would be more costly? We call this value-based insurance design. We've been very fortunate to have a significant uptake by public and private payers. And maybe more interesting to this group of journalists, it's one of the rare healthcare ideas that has not only multi-stakeholder support, payers, manufacturers, health systems, patients, but it also has very rare bipartisan political support. Because while cost of care is the focus of many of the AHCJ journalists, I think what's very interesting is my most tweetable soundbite is Americans don't care about healthcare costs. They care about what it costs them. So our focus on out-of-pocket costs has turned out to not only be important from a policy perspective, but very interestingly, Joe, from a political perspective, because as we think about whether it be a cost of hospitalization or what's being talked about on the Hill today about insulin prices, while insulin prices are important to important decision makers, it's what my patient pays at the pharmacy counter that really matters. And that distinction between total costs and out-of-pocket costs has proven to be an important one in the fact that there are a whole bunch of people might argue on the total price, Joe, but most people would agree that my patient should not have to have a bake sale to get her mammography.
That's a very, very good point. And it doesn't happen anywhere else in the world, at least among large industrialized countries. where if you go to the doctor, if you talk to anyone who has been to Europe and, tripped and fell and turned their ankle, they go to a hospital, they pay their 40 euros or whatever, and they're done, right? But here in America, that doesn't happen. And because of what you said, patients care about what healthcare costs them. And that's what is at risk under this decision, Braidwood versus Becerra, which is the case in Texas that's the Department of Justice and others are appealing. So it's wending its way through the courts. And I want to talk about that because, it's so important. What there are cost and clinical implications that you mentioned. And so I want to get into that. I also want to talk about the breast cancer screening issue that was recommendations that came out yesterday, but we'll get to those in a minute. Can you talk, you mentioned recently about if the ruling is upheld, the Texas judge's ruling is upheld, it could have a profound impact on how much people have to pay for healthcare. Can you talk about that in terms of preventive services?
Yeah, if you don't mind, I'm just take a step back a little bit and talk about the history of the preventive services provision, and then, of course, the potential implications of its legal overturn. So it's somewhat interesting that my policy experience is from the cartoon Schoolhouse Rock. So I'm an academic physician. I had no plans of being working in applied policy. And I was very fortunate in the mid-2000s to have some astute government relations folks basically say this idea of setting cost sharing based on the clinical benefit instead of on the price would be something that might be of interest to federal, state, and local policymakers. And it turns out the idea of value-based insurance design, Joe, is not some politically derived idea. It was largely our efforts with large private and public employers who made the decision early on that they were going to set their insurance products and actually allow people to get certain services to treat their hypertension, their diabetes, their heart disease, their depression at more coverage generosity than services to treat to allergies or toenail fungus or other types of things. So we brought this idea to the US Congress, and it may come as a surprise to many of the listeners that the initial attraction to the concept of value-based insurance design was driven by Republicans. And we were very early on working in a bipartisan way across the aisle, both in the House and the Senate, about certain ideas to bring VBID principles to Medicare and the Veterans Affairs group, areas, vulnerable populations that I really felt were a top priority to me, given my concerns about underserved populations, communities of color, and those with multiple chronic diseases. So fortunate for me, 2008 came around and national healthcare reform was on the table for the first time in over 40 years. And in the early stages, value-based insurance design, particularly around preventive services, because of the popularity of services that would prevent disease and manage early diagnosed disease so they wouldn't have complications, they were in every version, Republican and Democrat, of the draft ACA bill. And it's important to point out moving forward, in every one of the repeal and replace ideas, except for one of the 40 plus, included the idea of removing cost sharing for preventive care services. So a rare bipartisan before the politics situation came in. It turns out that this 3-paragraph section of a 900-page law that I helped draft gives authority over 3 organizations to designate high value preventive care services that are required to be covered with zero cost sharing. This includes the United States Preventive Services Task Force, the vaccine group at the CDC, and women's and kids services under HRSA. So that now totals up to today somewhere around, depending how you lump or split, around 100 preventive services that all public and private payers that are not grandfathered, which means they have not made a single change to their benefit design since 2010, must cover without cost sharing. So the good news, as my mother would say, I can't believe you had to study. If you make people pay less for something, they'll buy more of it. But the successes of this small part of the ACA, very importantly, incredibly popular. No surprise to you and me. Who's against the idea of free screenings for multiple diseases and cancers, shots for kids and grown-ups, and things like support for young mothers and other types of things. And it turns out that every poll ever done has shown that the preventive services provisions are always in the top 5 of the most popular aspects of the ACA. They also poll incredibly well among Republicans, suggesting that, again, who would be against these things? And our group and many others have shown that 150 million Americans before COVID have received improved benefits for preventive services because of this section of the Affordable Care Act. And that number probably grows substantially because the same small section of the ACA was amended to allow for no-cost COVID testing, vaccines, and treatments. And as we record this today on May 10th, with the public health emergency ending tomorrow, on May 11th, there might be changes in terms of how coverage for COVID services might be handled. So the good news is widely popular, implemented quite well. And for those of us like myself who care about equity enhancement and disparity reduction, it should come as no surprise that all of the studies that looked at issues of race, income, or chronic disease burden show that those underserved populations have benefited the most from the preventive care mandate. No surprise to most people. So what happened on March 30? March 30, you mentioned a case in Texas where it was deemed by a court that one of those 3 organizations, the U.S. Preventive Services Task Force, because of the issue of how these members were appointed, the recommendations were deemed unconstitutional. So currently, we have 46 of the 90 plus services that are currently covered 100% that have received an A or B rating from the U.S. Preventive Services Task Force. And those services and those recommendations, if the ruling is upheld, it'll be no longer required by plans to cover these 46 services 100%, meaning no out-of-pocket costs. And you can imagine the clinical and economic and equity implications of this ruling, in the fact that if you look at the myriad of services that are fully covered, the fact that Morning Consult has already shown in a survey that 2 of 5 Americans would not get these preventive services if they were asked to pay. So I'm particularly worried about any changes in the benefit design. I take it personally, the issue about this ruling, and I'm doing everything I can and would ask all of the attendees to help me advocate for some type of permanent guarantee that this, what I like to call no-brainer policy, can be codified and not have the potential to be overturned as it moves through a likely lengthy and contentious court battle.
You mentioned that 46 services. We'll put that. Can we put that list up when we post the? Is that list available from your organization? I guess that's
absolutely. I'm going to provide for you and all the fabulous attendees who I'm seeing coming in. We have a table that we update regularly. I think some of the people have attended today because there were 2 new U.S. Preventive Services Task Force A or B recommendations just in the last week. We'll talk about that later. But I think a really interesting point, and I've seen this in some media stories and would love potentially hear during the Q&A from some of them, is that an interesting nuance of this first ruling, understanding this is not the final ruling, that not only are the HRSA and the ACIP recommendations preserved, so it's only the task force because of this appointments clause are deemed unconstitutional. But also in the initial ruling is that any recommendation before the signing of the ACA in March of 2010 will be upheld. And some of the early initial reporting on this from public health advocates is, oh, this is not so bad, because there were a lot of recommendations before 2010. And where your listeners will see in my table is that not only have there been about 15, a third of the A and B recommendations since 2010, so they're immediately off the table, but another third of the 46 have been changed in such a way that we would be going, what I like to say, back to the future in relying on older, in my opinion, obsolete, not the most up-to-date science in terms of what people would have to cover. So I am a little less optimistic and happy about the back to the future part, which some reporters have suggested is a relatively good thing. I have concerns about that, and we could talk about some examples of that. I'll give one, I do a lot of work, and I'm looking at some of your attendees in colorectal cancer screening. And it turns out that if we went back into the future to the pre-2010 colorectal cancer recommendation, it would be changed significantly. Same in breast cancer, which we'll talk about later. But as many of your attendees know, that the colorectal cancer recommendations changed from 50 to 45 in terms of the age of initial screening. So that's 20 million Americans now who have zero cost-sharing access to some modality of colorectal cancer screening. Point one. So 20 million people, their coverage could potentially go away. The second is the modality of screening. So some of you, like you and me, who watch sports, see advertisements on TVs for stool DNA tests or Cologuard. It turns out that that was recommended as a no-cost modality for colorectal cancer screening after 2010. So not only would the populations change, but the modality of screening would change if we went back to the 2010 ruling. So I'm all in, as you know, and would hope to get any information or insights about how we can bring more attention to the clinical and equity implications of this ruling if it were to be upheld, as well as we've written about extensively, it is a one-sentence legislative fix. And I understand that as sports fans, Joe, it is a Hail Mary for us to think about bringing about a legislative change in this divided Congress, but I'm optimistic because it's hard to be against the idea of preventive care. It's even harder, in my opinion, to be responsible in taking preventive care away from millions of Americans. So I will continue to beat the Horton Hears a Who drum and let everyone else have the drum beat with me to see if we could ultimately codify this incredibly popular policy before it's left in the hands of the Supreme Court.
Sure. I see that one of your colleagues at the university at the VIVID Center posted the list in the Q&A. So anyone can access that. And if you have a question, you can do just as Kara Gavin did, Mark's colleague there at VIVID. You can click on that link and you'll get the list of the 46 services that are at risk here. And that one is updated as of today, she says. So thank you very much for that.
I can't thank my colleague Kara Gavin enough for all of her efforts to help get the word out. She puts up with me, which is not easy. And again, it takes a village to make this happen. So I'm most appreciative.
You want to talk about the clinical implications and the equity implications one before the other, or do you think you've covered that, or what do you think?
No, I'll just, I think, again, this audience is so important to me. I like to tell people, all of you journalists who deal with academics, you've heard the adage, publish or perish. Well, I like to say I published and I still perished. And I rely so much on all of you to get the word out. So people are inundated with different healthcare topics, whether it be the recommendations from the task force yesterday.
Oh, I think you just froze.
Women's reproductive rights.
I think you're back. You froze there for a minute, Mark.
Sorry.
You talked about the recommendations that were released yesterday from US PSTF.
So what I was trying to say is, I'm sorry about that. You could blame the University of Michigan internet. What I was trying to say is, we all have attention deficit disorder when it comes to news and healthcare and specifically, but I think the reporting on the Braidwood case has largely been around legal issues and the ideologies involved and other types of things. Yes. And I would love to bring more attention to the fact that 150 million Americans, their access to free preventive care is at risk. And although we've done some work and you might have seen a letter from the health plans to say until the case is decided, that most health plans will keep their preventive care coverage in place. One is there's no guarantee of that. And two, which is very important given the timing of this recording, Joe, is that it doesn't include what I call how this policy is a gift that keeps on giving. The U.S. Preventive Services Task Force sometimes has up to a score of services they're analyzing in the various stages of their very transparent, very rigorous review. And at the bottom of the table that Kara showed, there are half a dozen services that have a draft A and B rating, including the new recommendation released yesterday on breast cancer screening. And while I have some confidence that Most payers will keep in place the current services at some level of coverage generosity because the inertia is hard to overcome. And we've shown that these services tend not to cost very much compared to a relative market basket of healthcare services. But I am concerned, say, that will payers automatically start covering mammography at 40, even though the law says they have to cover it at 50. And there's several other examples, such as screening for anxiety and other things that are so important for us regarding our individual population and public health, that why some type of confirmation of the preventive care provision or a guarantee that will remove any confusion, because as we've shown, even when things are by law for free for over a decade, people still don't know about it. They still don't understand. And if there was any barrier that you would put in place, Joe, as you know, to potentially dissuade someone from getting one of these potentially life-altering or life-saving screening tests, they won't get it.
See, that's the problem, is so many patients face so many bills when they go to the doctor, go to the hospital, go to the ER, urgent care, whatever it is, that they can't separate, oh, this was part of the ACA that was taken away. This is part of my insurance that is low value. But what you're saying is that under this ruling, patients would have to pay more for very important preventive services that prevent high costs and bad illnesses down the road.
Let me give you another example, because I know it's often helpful to provide some more granular context. So many of your colleagues are listening have heard that one of the priorities of this current administration, with bipartisan support, is a intervention to eliminate hepatitis C virus. So this is one of the most common causes of liver failure and liver transplantation in the country. And miraculously, since I've been practicing medicine, Joe, we didn't have a name for this virus when I started. Now we have the entire genome coded. We have pills that you could take for 2 weeks with hardly any side effects and cure over 95% of the people. Well, it's very interesting that most of the writing from journalists on hepatitis C is around the cost, which is completely fine. There also needs to be some conversation about what a miraculous breakthrough this is, given that we had no effective treatments for this really serious condition when I started practicing medicine 30 years ago. So one of the new A and B rated services, Joe, is a one-time screening for every adult at average risk in the US for hepatitis C. Right? So you might have heard that my University of Michigan colleague, Francis Collins, has been recruited out of retirement after leading the NIH for decades to lead this hepatitis C eradication program. Imagine the success of the eradication program where everyone gets to enter it with free screening, as opposed to the program that you enter the program where you're at risk for paying out of pocket for the screening test. It is automatically putting an albatross around that program's neck by saying, oh, we want to eradicate hepatitis C, but we won't allow for screening. We want to take on mental health disorders like depression, anxiety, substance abuse, but we are going to make it harder for clinicians with their patients to be screened for these potentially treatable conditions. So everyone knows how important prevention is. What's been very interesting to me, Joe, is that while many of your colleagues have reported on a whole bunch of people who are saying something bad about the ACA, to my knowledge, I have not seen a single policymaker come out publicly and say they strongly support the Braidwood ruling, which would effectively take free preventive care services away from over 100 million Americans.
I know that there's broad support for that, and anyone who gets a preventive service, like screening for cancer, for example, or screening for diabetes or hepatitis, and gets that for free, that's huge. So you mentioned that the VBID Center was working on legislation that could undo the damage. Is that the one sentence fix that you mentioned, that you talked about?
So there are other experts that you and many of your colleagues know that understand the legal implications, but the crux of the non-attorney problem, which actually, in my opinion, has some legal merit, is to make policy in the US. This goes back to constitutional law. You have to be an agent of the state. And being involved in those deliberations in 2010, in that one of the strengths of choosing the U.S. Preventive Services Task Force, this non-governmental agency to determine the services that would be covered 100%, was in fact they were non-governmental. And most people applauded that. But it turns out this very granular nuance of constitutional law says that a non-governmental agency, like the U.S. Preventive Services Task Force, because they were not appointed, thus the appointment clause, that they cannot make policy. So it turns out that there are two ways that you and I as non-lawyers might figure how to fix that. One is to have the members of the task force approved by the Senate, which would not allow us to go back to take care of the existing services. And many of my colleagues I know, task force members, would not like to go through the scrutiny of a Senate approval these days. And I'm looking at you, you know that. The second, which is the one I endorse and have been talking on the Hill about to both Democrats and Republicans, the one sentence fix is that the approved A and B services by the task force would also be approved by the Secretary of Health and Human Services. So that allows someone who is appointed to actually make the policy as opposed to the task force. While what I like about this and what I don't like about this, Joe, is that one, it takes care of the legal challenges 100%. What I potentially don't like about it, but I think from a political standpoint might be a benefit, is that, remember, the Secretary of Health and Human Services is a political appointee. So say, for instance, that there's a particular A and B rated service that a specific administration or party doesn't like, right? So while that party is in position, they could say, I don't approve it. So moving forward, if there's a contentious area, and you know the most contentious area in this case is pre-exposure prophylaxis, or PrEP, to prevent high-risk individuals from getting HIV, that this would give the secretary an opportunity to say, not under my watch. And while I would personally strongly prefer to have all the A and B services be codified, which is my goal, I think our one sentence fix plays a little bit more to the idea that at least the party in charge can make some decisions. And that includes just this one sentence addition that says the secretary would ultimately have to approve the A and B recommendations to have them go into policy and law.
Yeah, that makes sense to me. Well, you brought up the A and B services from the U.S. Preventive Services Task Force, and one of those came out yesterday. Well, no, they both came out in the last week, you said. One was on breast cancer screening for women under 40, and particularly they were aiming at more screening for Black women because they have been underserved in that area. So that's a significant change, right?
Right. So this has, again, good timing, bad timing, right? So as I try to bring attention, and I'm looking at the list of the attendees, two specific issues, one of which hopefully for our next conversation is the need to ensure that people who undergo ACA mandated cancer screening can actually get coverage for the entire cancer screening process. We'll put that on your whiteboard for now. The second is what happens when you get this gift that keeps on giving, when the newest best science basically leads to a significant change in either the populations or modality of screening. So this change in mammography recommending from 50 to 40 impacts close to 20 million American women. And the fact that if Braidwood is upheld, this new population that has been deemed by this organization to benefit substantially from increased screening access is not mandated. Of course, any insurer can decide to put it in place, but Joe, you know that most insurers are not running to cover things very generously. That's why VBID exists. But the other point that you mentioned, which is the case of several of the updates for colon cancer screening, for lung cancer screening, and now breast cancer screening, focuses on Black and brown communities. And the fact that the biology and the incidence and the treatments are different in terms of the access, affordability, et cetera. So imagine why I strongly support any equity enhancing policy, which I believe this is one. The direct implication of the Braidwood decision, if upheld, would not, or at least slow, the uptake of coverage for this new recommendation, because it goes from a shall, which is the current approach that you have to do it, to a may, which is you could do it if you want to, but as someone personally is more of a may than a shall person because I'm a bit of a wimp, I really like the fact that this is a shall, because it takes all confusion off the table, and you get to tell people, like I tell individuals now, that if you decide to go for one of these 90 services, you do not have to pay out of pocket for it, period.
90 services those are recommended by, those are the A and B recommendations from the USPSTF?
No, 90 plus, so 90 plus for the entire preventive services provision. 46 of those are the task force. And I think this is an important point that some of my legal scholars have told me. So good news for now, that as I said, task force recommendations pre-March 2010 and the HRSA and the ACIP vaccines are protected. Thinking about where the puck's going to be, Joe, as opposed to the puck is, and I'm going against my usual optimism to a little bit cautiously pessimistic individual on this, is that there is a greater than 50% chance in their eyes that through the appeals process, that those protected services like the vaccines and the women's and children's health will be brought in again, because that was one of the initial foci of the case. So I am one of the reasons why we have to do this now, as opposed to waiting, is that if there is a reasonable chance that through the circuit court process that the HRSA recommendations, which includes contraception, which is the biggest one that people have been pushing back on since the preventive services provision was put in law, then I believe the culture wars will take over, and our likelihood of getting reasonable folks to protect preventive care will very, very unlikely happen. So why I'm doing this now and not waiting like several other advocates are, let's see what the court says, because I think this could only get worse. Again, I'm not a lawyer, but predictions are dangerous, particularly those about the future, as Yogi Berra said. So I'd rather not wait, and would love to have any of the folks on the line help bang the Horton Hears a Who drum to see if we could get enough multi-stakeholder and bipartisan support to guarantee this immensely popular and incredibly impactful policy.
Well, nicely done with the Yogi Berra reference and the Wayne Gretzky reference with go to where the puck is going to be. We have some questions from the audience. One is, do you have any data on how many of the 46 preventive services that are at issue were covered before the ACA?
Yeah, so this is where, I'm not a Zoom expert, but so there is a table, which I believe Kara has already put in place, which is updated.
She posted it, yes.
Yeah, so that is it clear, and there is a Health Affairs Forefront post, which is also in a link that Catherine will provide, or you could go to the VBID Center website, vbidcenter.org. All you ever want to know about the clinical and equity implications of Braidwood, all there for you. And feel free to reach out to me personally if you're interested in writing more about this issue.
Right. That sounds good. I wanted to, we didn't talk about the tuberculosis recommendation. So there was the breast cancer one, which is important, but the other one this month, earlier, it was last week, was regards latent tuberculosis infection. Do you want to talk about that a little bit?
Yeah, I think it's probably more important, Joe, to not talk about the specifics, but to understand that what's so amazing about the practice of medicine, right? And you all report on this, it changes every day. New information to tell us more of this or less of that. And that's really what VBID is about. So we follow clinical recommendations. Say, if it's really, really good, we argue like the insulin copay cap, right? My patient should not have to have a Kickstarter campaign to afford a drug that if she doesn't take, she might die, right? So it's not just preventive services, it's all about these things. So imagine this nuance of the ruling that says we'll continue to cover 100% the recommendations from the US Preventive Services Task Force pre-2010. I know, Joe, you and I are young guys. 2010 is a long time ago. And we've written about a lot of really incredible biotechnological advances and innovation. And imagine whether it be in communications or computers or how we listen to music, that we had to go back to 2010. Some people think about the good old days. I don't like the good old days when I talk about modern medicine. So imagine these organizations that are included in this dialogue and elsewhere that are culling over the greatest information to decide what to recommend in guidelines and in recommendations. and in coverage decisions. And if we were forced in the TB case or any of the other 16 cases on that table that there have been significant changes from a current A and B to the previous recommendations that existed pre-2010. In some of these situations, Joe, I would almost rather that there wasn't an earlier recommendation, that no recommendation might be better than an older one, given that science changes so dramatically and quickly.
I see. And A and B recommendations from USPSTF are shall recommendations?
They
Do I
are
have
now,
that right?
they are, as of today, outside of Braidwood, they are shall. So for instance, when the colorectal cancer screening guideline was confirmed, every non-grandfathered health plan in the country had to drop their age which they covered colorectal cancer screening from 50 to 45. The same holds true once the draft breast cancer recommendation goes from draft to final. The plans have one plan year to change their benefit design from whether it was pre-deductible or had deductible was applied or not. These now are $0 deductible exempt.
The draft is supposed to go final in June, I think, June 5th, for the breast cancer one. We have another question, which is, has bipartisan support for value-based insurance design dried up in the current divided Congress, do you think? Or do you have any hope that some of these needed changes will be made because there's support across the aisle?
Yeah, so I'll change my reference from sports to the 100-acre wood. So in the world of Winnie the Pooh, I'm a Tigger guy. I do not have a dog in the fight. I've been very fortunate to work over now 2 decades with policymakers on both houses and both sides of the aisle. I think I've found that there's interest in the idea of preserving preventive care. I have no ability to predict what the likelihood of anything getting done in this divided Congress, but it's not going to stop me from advocating for a permanent fix or guarantee of again, this widely popular, impactful, and equity-enhancing policy. And again, I like to say, for those of you who cover DC, I didn't know the word ask was a noun before I went to Washington in the 2000s. And my ask of you folks from HCJ is to bring more attention and to bang the Horton Hears the Who drum. That's one Dr. Seuss reference, and allow me to remain Tigger and not become Eeyore in my pursuit in bringing attention to VBID. The good news is, as a sideline, Joe, you know that in the Medicare program, which is not covered by the Becerra case, the Braidwood v. Becerra case, the Medicare Advantage value-based insurance design demonstration, started by President Obama, expanded by President Trump, and further extended by President Biden, suggests that there is, bipartisan support for the idea of removing out-of-pocket costs for high-value services. Another area that's of great interest, and many of the people I see on this list have written about already, is the insulin copay cap, and this is being discussed in the Senate Health Committee today. Most people don't know that this kind of flagship accomplishment of the Medicare insulin copay cap, signed into law by President Biden in the IRA, was actually put in place by President Trump as a model test in CMS called the Senior Savings Plan model. And I was intimately involved in that, as I am in any policy to try to lower out-of-pocket costs, whether it be preventive care, which we're talking about in the Braidwood decision, or in chronic disease, which has currently been my focus, largely because, Joe, preventive care was taken care of by the shall of the ACA, and it allowed me to further focus on high-value services, not that are deemed preventive, but extraordinarily high value in the management of chronic diseases. And that, as you know, that has been largely our focus, because we didn't have to worry about it, because preventive care until Braidwood was mandated to be covered under the ACA preventive services provision.
So you've seen some bipartisan support for these things, and what you're saying is we hope that the bipartisan support will continue, because everyone's in favor of lower costs for healthcare, I think, especially even those in Congress.
Can I just say something quickly? One last quick thing on that. So one is, it's the point that as people are coming in and going, it is near universal that people support the out-of-pocket cost issue. And that's why I would lean on your members to do a really good job to distinguish between the price of a bypass surgery and what the patient pays, what the price of insulin is and what the patient pays. And I, worked so hard to try to distinguish this thing. So one last example regarding bipartisan support in an area that most have probably not heard of, a bill called the Chronic Disease Management Act, which has been introduced in the last 3 Congresses in a bipartisan and bicameral way, led by Senator John Thune and Senator Carper of South Dakota and Delaware, a very intuitive bill that's a may not shall, Joe, where it gives health plans that have high deductibles more flexibility to cover these services on what I call a pre-deductible basis. In other words, you and I are pretty happy when January comes along, but there are millions of Americans in these high deductible health plans that when January comes along, they don't have the money to cover their deductibles. So the Trump administration put in a very popular program that allowed these health plans to cover 14 services on a pre-deductible basis, for which 75% of plans and employers have changed the benefit design to allow patients to have lower out-of-pocket costs for chronic disease services. The Chronic Disease Management Act actually allows these plans flexibility to cover even more services than the 14 allowed on a pre-deductible basis. The good news is plans aren't rushing to cover things more generously, right, Joe? But allowing them, if they want to cover them and not worry about the tax implications of the health saving account aspect of a health saving account qualified high deductible health plan is just a really good example of not only strong political bipartisan support, but also multi-stakeholder support.
Let's see if we can get some of these questions answered because they're good ones. My former colleague, Carrie Dooley-Young, asked, can we talk about how callback mammograms are not covered by health insurers? And, you get a screening mammogram and it shows something or it shows you need a callback. That's not covered. That seems crazy.
Well, your words, not mine. Carrie, thank you. I didn't ask her to plant this question. So before March 30th in Braidwood, some of the members know that my project, and one of the most frustrating parts of the ACA as it hummed along in its popularity, is I learned about 5 years ago that 4 cancers, Joe, that are mandated under an A or B rating from the task force: breast, cervical, colorectal, and lung. So cancer screening has to be covered first dollar. And the spirit of the law that I helped write was not just your first test in the cancer screening process, but the entire cancer screening process until you're told you don't have cancer, which we hope, but you do have cancer that is hopefully detected early that can be treated, will be determined. It turned out, and I'm not pointing fingers here, Joe, that all 4 of these cancers, and we have some references that, again, I could provide, show that we studied that a substantial minority and sometimes a majority of the patients who are screened for these 4 cancers who receive A positive, which is the reason why we're screening in the first place, have to pay non-trivial amounts out of pocket to be told they have cancer or not. So while I am really frustrated that people have to have a bake sale to afford insulin, I'm even angrier about what I call this cancer screening coverage gap, which Dan Gorenstein in Trade-offs has called cancer screening purgatory. That time between you're told your mammogram is positive, your pap smear or your HPV test is positive, or your CT scan or your Cologuard is positive, and told, oh my gosh, I need this second, sometimes third, in some cases 4 tests to be told whether I have cancer or not. So I have made it a very top priority to close this cancer screening coverage gap. The good news, thanks to folks, Kara Gavin putting out information on this and CBS News doing a feature story, we have closed the cancer screening coverage gap for colon cancer. So people who get a call back, as Carrie liked to said, that your stool test is positive, your colonoscopy must be free, both in commercial plans and Medicare. And Joe, I can't tell you the joy I get to tell patients, given the backlog for colonoscopy, that if they get a Cologuard and it's positive, their colonoscopy will be free, not like the patient who told me their neighbor had to pay $2,000 for a colonoscopy after their free stool-based test. So we've got one of those 4 cancers taken care of. I'm sorry to go a little bit long, but anything that you folks from HCJ could do to bring attention to this cancer screening coverage gap, we have advocated extensively, and this is not requiring a legislative fix, because the Biden administration fixed the gap for colon cancer. The exact same playbook can be used for breast, cervical, and lung. And when I get this braidwood thing out of my hair, Joe, I'll go back almost full time to try to see if we can make this happen. So Carrie is exactly right. There are several studies of showing that if you make women pay more for a follow-up, they'll go less often. And if you think about the high rate of women who don't follow up an abnormal initial cervical cancer screening test, extraordinarily high in communities of color. I understand finance is only one barrier to follow-up, but it's an important one. And I really do believe from our evidence for colorectal cancer screening, if you tell patients, by the way, if you're unfortunately have a positive initial screen, we will make it easy, not hard for you to find out whether you have a cancer diagnosis or not. You could see why your reaction was, that sounds pretty dumb. And I'm not blaming anyone, because there are technical coding issues between, say, a screening mammogram and a diagnostic mammogram. I do believe that people should be paid differently based on the sophistication of the test, but they should all come under the definition of screening, which is why any of you who are writing about the breast cancer new recommendations tomorrow, not only important by changing the age, it's critically important that we add in the final version that they stay firmly, just like we did in the colorectal cancer screening update, that the screening process includes all necessary diagnostic tests until the diagnosis of cancer or not is made. Thanks, Carrie, for bringing that up.
Yeah, it's a good point, Carrie. And also, she mentioned that there's a news peg for journalists by finding researchers who plan to comment on the draft, who could talk the draft about breast cancer screening. Talk about how it is a draft.
If Kara is still here,
please.
If Kara's still here, she did an amazing piece, which she's updated several times, on these 4 cancers and out-of-pocket costs. And Kara, I see your name in the list. If you could put that in the Q&A, it's a beautiful piece, and I give her all the credit for not only making it happen, for updating it as things have advanced over time.
She's certainly an excellent journalist and knows her stuff through and through. Mark, thank you very much for your time today and your expertise on these issues. It's you're so well presented and so needed in this confusing time, because people are making choices, as you know, between putting food on the table and getting the health care that they need. And that is not a decision that anyone should have to make. And in many other countries, you don't have to make it. But here in America, we do have to make that, some of us have to make that decision. So it's killing us, as you mentioned.
Yeah, I think literally and figuratively. I'm looking through the list. I want to call out my longstanding colleague, Pat Anstedt from Detroit, who just did an incredibly interesting feature on breast cancer screening, which kind of set the stage for the issues that we confront in paying to get diagnosed, the difficulties in achieving treatments, particularly state-of-the-art treatments. So I'm hopeful that I'm seeing a lot of the names I've worked with in the past. Feel free to reach out if you're interested in doing more on this subject. As I said, I'm so appreciative of the journalists who helped me go beyond I published and I still perished, because without you, I think most of our successes in the policy realm, as opposed to the academic realm, wouldn't happen. So please view me as a resource, and I'd love to collaborate with each and every one of you.
Well, you always respond promptly, and I appreciate that about you, Mark, and you have a great team up there in Michigan. So thank you. We will post the recording along with links in the next 24 hours. It usually goes up quickly in a day or so. So watch for that if you want to see it again. So thank you very much, Mark. We appreciate your time and your expertise on these important issues.
My pleasure.
Pleasure to work with you.